We have a really full agenda for everyone today, and we hope that this is an engagement opportunity for all of us as part of this learning forum. When you come in, if you don't mind adjusting your Zoom name to add the affiliation that you belong to, it will be great to get to know the audience here in the virtual room and understand, who is joining us from across all of our stakeholder groups. So with that, I'm going to go ahead and get started with today's meeting. Welcome you all again. Everyone has been muted upon entry to minimize background noise. You do have a few channels of communication here. During the presentation, everyone is welcome to chat in. You can say hello, you can ask questions, provide feedback, add a comment throughout our presentation. When you do use the chat function, please make sure that your messages go to everyone to not miss any of them. And if you would like to ask a question live, we kindly ask you to raise your virtual hand. That would allow us to pinpoint you and make sure that we get your question in. So as people are trickling in, I will just say one more time, if you don't mind adding your affiliation next to your name via Zoom, that would be wonderful. It will allow us to get to know the virtual room, and it will be a good opportunity during our questions and answers section. So thank you. If there are any technical issues from your end, you're not able to hear us, so you can see the presentation, please, you can contact Demry. She's supporting us behind the scenes as our host, and her email is displayed here on the screen. Perfect. For today's agenda, we'll start with our welcome. It has been a bit of a break. Our last meeting was in November. So we'll catch up there briefly and then segue into an overview of the social determinants of health clinical care FHIR implementation guide, STU2 version, as well as office hours section, which it is the first one that we're hosting today. So we're really excited to start the new year with some engagement and an opportunity to answer some of the questions that were received. Then we'll segue into our pilot partner presentation, and it is an honor to partner with the District of Columbia Community Resource Information Exchange. Kudos to the entire team. They have prepared a really awesome presentation for all of us. Then we'll segue into the partnerships and opportunity discussion. Some of you have been very active and have entered our Confluence space and signed up as pilot participants. So we would like to give you all a shout out and an opportunity to share the potential pilot that you're looking to stand up. So we'll be there for about 20 minutes or so, and then we'll close out today's session. And thank you. We'll make sure that you have the link for our Confluence. And if it's your first time, that is our knowledge management site that houses all of our materials from this presentation. Okay. For some of you who are very familiar with the Gravity Project, we always like to emphasize that we are agnostic to the systems, tools, and vendors that support the data exchange of social determinants of health. This is our standing antitrust practice that we fully comply with, and we kindly remind you about our principles. And we also want to give a warm shout out to our sponsors who have enabled us to start this pilot's Affinity group phase. And we're so excited to continue your engagement. This is our meeting number 4, and the next one will be in February, a month from today. And without further ado, I do think I see Corey in our audience. I would love to ask him if you don't mind. There you go, testing your audio and video. Perfect. We can see you. And I just wanted to thank you, Corey, for being here today. I'm going to do just a quick introduction in case that Corey is a new face for some of you. Corey Spears is a member of the Gravity Technical Workstream. He is the Healthcare Technology Principal, assisting with the further development of the Social Determinants of Health FHIR IG, thanks to the kind support of MITRE and CMS Office of Burden Reduction and Health Informatics. And we're very excited to have you as part of the team. And I'll hand it over to you now.
Oh, thank you, Gabby. Can you hear me all right?
Yes, we can hear
All
you
right.
just fine.
So we'll start off by giving an update on SU2, sort of the differences in the current work, and then we'll open up introducing our office hours session. So to start off with, SU2 was balloted back in January of last year, and we had a good reconciliation process here, and we're able to publish it in November, on November 21st of 2022. There's plenty of advancements. Probably one of the most notable is the additional kind of patient involvement aspects. So we changed the task, which was just the general task profile, to a referral task. So that is a task that's supporting the referral and the service request. And that was changed so that we could add this patient task profile, which enabled management of the assessments. So the questionnaire response, being able to assign that to a patient. Also added a few more profiles, including the healthcare service and location profiles, which are used in the patient task for contact information, so that the individual can contact the community-based organization. We added a draft set of personal characteristic observations dealing with REL-SOGI, which is the race, ethnicity, language, sexual orientation, and gender identity. So those have been added as a draft status to the IG. And then there were a number of must support and element definition changes in order to support implementer feedback. And so things that were identified by implementers through the Connectathon or through pilot efforts. We've also defined new workflows, so including with that patient assessment, the questionnaire, a workflow involving the patient, including ongoing communications, support for multiple service organizations, and so those would be those that providing ability to do a multiple referrals off of a single one. So there might be multiple tasks that are chained for an organization that manages multiple types of services, and then support for workflows involving patient or client and CBO applications. And so this is the state where yes, this is the instance where an organization such as a care a community-based organization might not have their own FHIR server, but do need to engage. And of course, patients wouldn't have their own FHIR server. And so they may be using applications by vendors that support FHIR interactions. And so we added workflows to address those. Then we have value set changes. So mostly that includes moving over to US core value sets, US core being the FHIR implementation guide that is well used and required in a lot of spaces by certified EHR technology. And so in further alignment to that US core, move to those value sets. We also added value sets for the new profiles that we mentioned and to support different profile changes. Next slide, please. We also improved guidance, specifically around mapping instructions, and added guidance for the use of the task profiles. Improved descriptions of the functional use cases, and the functional use cases provide scenarios with the different workflow patterns that we have, and improved the exchange workflows, which is the more technical description of those interactions. And then the capability statement was updated. For those that aren't familiar, capability statement is basically a sort of a computerized requirements document, or a statement of capabilities by an implementer. And so what this means is for our capability statement, it defines requirements for implementers, and specifically around which profiles need to be supported, search parameters, and things of that nature. And so we've updated some of the names and the contents updated the names of the capability statements to support more directly support the new workflows that we've added. Added certain search parameters, and then added some support for what we call the capability statement expectations, meaning as a requirements statement that implementers must support certain things as certain profiles. And then we made some changes to the capability statement to better support the use of subscription and pointing to the correct profiles. Next slide, please. So that is the scope of the STU2 that was published back in November. We are continuing work right now in the technical track in our work stream in order to continue to build on those improvements with an STU update. So in sort of HL7 speak, an STU update in this case is going to be an unballoted update. We're not making any kind of constraint or requirement changes. There aren't any real substantive changes that we're looking to make. So what the process is, we'll go and review it with the larger community and the sponsoring, co-sponsoring work groups in HL7 and get the appropriate approval so we can publish a new version. And the idea with this version is that we're providing narrative implementer guidance and making it more approachable and more understandable so that those vendors, those organizations that have not been involved directly in the development of the IG can understand it more fully and be ready to implement it. And we're planning this for the first half of this year. So far, our primary opportunities we've identified as workflow models and descriptions, more profile descriptions, better description of use of the task, and some navigation and work and flow improvements. So that's our current effort. Moving on to our approach with that is we're going to
Excuse me, when are you taking questions about what you just reviewed, which was quite substantial? Do you want to wait till the end?
Yes, sure. I'm almost done.
Oh, okay.
Once I go this side, I can sure I can take questions if that's and we have a lot of people on the call. I don't know how we want to manage this.
Yes, I think we do have a space for questions right after Corey's presentation for all of our audience, and we welcome your thoughts. Please kindly raise your hand so we're able to track who would like to ask questions live, and the chat is available for any comments as well. Thank you so much.
Thank you. So our approach to this is just so everyone's aware, and this fits within the HL7 processes, is we have a core team that's going through doing a triage. We've identified the areas we think can be used to improvement. We're always, of course, taking additional suggestions. We're going to be entering tickets for all these things in a tracking system. We're going to be then presenting it to the community. We will be reviving the sort of the community fire IG weekly meeting, which was being held at 3 p.m. Eastern on Wednesdays. We're looking for keeping it that same time here soon. And then as we get acceptance there, we'll move on to the patient care work group and getting approvals and go through the SU update process. So now it's time for our office hours. This is a new slot here on this meeting that we're introducing here. And the idea here is that we want to open up dialogue and communication and support the various communities here that are involved with Gravity. And this is, we want to facilitate a forum for open discussion and questions. And so this will be a great forum to discuss our experiences, our challenges, address any questions, and find things that we might need to further address and look forward to addressing in future versions of the implementation guide. We encourage everyone to submit inquiries via email. So that we can organize beforehand. We have a limited time here. We did have some questions submitted, but before we go into those, I think there was one particular question about the material that was just reviewed here.
Yes, thank you, Corey. So we'll pass it over to Lucy, if you don't mind. Feel free to open up your mic. Thank you.
Thank you. And thank you for this very thorough review. I had a question about the capability statement. If you could maybe go back to that slide. Basically, from what you said, do I conclude correctly that some entity that wants to participate in this needs to comply with the capability statement? If that's correct, then what happens if they don't? How does that sort of work?
Well, there's not really, okay. The capability statement there is meant to express the requirements as identified in the IG. Its practical use is a little bit varied. It depends on which space it's being used in, right? So if there is a regulatory requirement or some kind of certification, those can be checked and verified and tested upon. In our space currently, we don't have that. It's good for testing. It's good for to meet those requirements in order to enable interoperability. We understand that this is somewhat a new space, and there will be organizations that are able to fully meet all of the specified requirements, and some that might not be able to. And so this is a growing space. The capability statements are they specify the requirements, but they are also may, should, and shall. There are only a few shall requirements, and so there's varying degrees of requirement.
So this is really guidance. This isn't a requirement, at least not yet, to participate in this, right?
Yes, and I would note that these are requirements that are separate from necessarily any particular effort, particularly in the pilots. Like in our pilots program, we have tiers 1, 2, and 3. These capability statements don't apply to tiers 1 and 2, right? And for tier 3, what we're trying to do is look for improvements both in the guide and in the industry. And so there's, to my knowledge, there's no expectation that you can't participate in a pilot if you don't meet every requirement in the capability statement. That doesn't exist. What we want to do is understand why something isn't being supported, and if there's changes we need to make to the IG to make it better, or maybe maybe our requirements are too much, or maybe there's other approaches.
That's very helpful. Thank you very much.
Thank you.
And Corey, if it's okay, I'll just quickly add that part of our tier approach is to be able to meet our implementers where they are. So we're trying to offer a pathway, tiers 1 through 3. And for the Fire IG exchange specifically, it will be tier 3 level. And we're gonna go a little bit over that as we present our pilot participants and sort of their efforts. And really, thank you, Corey. And let me know if whenever you want me to go back to the office hour questions.
And I'm glad you asked the question, by the way. We don't want to scare people off with this. This is the goal here. This is what we're trying to get to. And we're not cutting anyone off from participating or being a pilot that might not meet the goal yet. So thank you for asking that. All right, so how much time do we have left in this session?
For the questions and answers, we have 10 minutes or so. You can, up to 15 minutes, Corey.
Okay. So I will get on this here. So we had 3 questions submitted. They're very good questions. I think they'll be good to discuss, and I'd like to hear and other, everyone's opinions sort of on this space, so that we can further explore and see what we can do to address the concerns. And the first one is about licensing of proprietary vocabularies. And this one particular issue goes well beyond just RIG. It involves sharing of data in general, even beyond FHIR and HL7. And there are code systems in our IG and in other implementation guides that use proprietary code systems that have licensing requirements. Specifically pointed out is things like CPT. SNOMED CT is licensed, but it has a different sort of licensing agreement where we're allowed to use it in the US and share description along with the code. CPT is not as clear. There are others such as 211 LA as well. Now, currently, we don't have any requirement on 211, but that may change in the future. And there's also other guides such as the HSS, that's the Human Social Services Directory guide that does mention as well. So with that, the concern, their interest expressed is that systems that don't have or don't use these codes as their main line of business may not license these, or it may be too much of a barrier to license these code systems in order to be able to provide a display for them and for their users. So CPT isn't an issue for a provider because that's in their main line of business, they're going to have it licensed. But for consumer apps, for community-based organizations, that may be a challenge. So with that, I guess maybe give a couple minutes of discussion or thought on that. And if no one speaks up, I can give some additional background what I've done or we've had to do or looking at in other areas. So,
Corey, I'm just waiting to be polite to give other people a chance. This is Lisa Nelson, and then I will follow up from if anybody else doesn't want to speak first.
Okay, and we do have a full agenda, so
yep.
I'm going to ask people to be brief where they can, and note that this is an ongoing challenge, and we're working on ways to address it.
Super. So many people, I'll just try and be very brief. Many people do not know about this problem, and they don't run into it until well underway. And this is something that MaxMD has been running into for a long time since we've been working with the Karen Blue Button IG, and it's a major issue to be able to provide meaningful information to patients, which they have the right to access. It puts apps in a really tough spot, an unsolvable really kind of position right now, because even if you want to try and get licenses, not all of these organizations offer appropriate pathways that an organization can just go to the website and click on the link and buy the license. It's a convoluted process that is not designed to fit very well, and it's an administrative burden to try and figure out how to get the license that you need and pay for it and then re-up it year after year after year. So I think that it needs to continue to be on the forefront of our minds, especially for guides like Gravity or any guides that are trying to provide information in an equitable way to all stakeholders in the health IT community, not just the big players who can afford to do this, but for social care organizations and for people. This is a real barrier.
Thank you, Lisa. And you're absolutely correct, particularly in spaces like what we're dealing with here in SDOH, that there's a lot of organizations, consumers that need to be involved in the process. And so a code is not going to do them any good for the most part. So that's something we need to consider both in the selection of our code systems that we use and then in our kind of requirements or implementation guidance. And so at a minimum, I think we need to kind of recommend that systems not just include codes, but that they provide a display or a text along with those codes so those systems can use it. Otherwise, we're not going to end up having interoperability the way we want or need. As I mentioned, this is a larger issue that is ongoing, and we need to work with HL7 to see what can be done. I know there's vocab efforts. There's a group that deals with vocabulary and working with these external code systems authors to secure some kind of understanding on the licensing and capabilities. So
Thank you. Really appreciate Corey's and Lisa's suggestion. I just wanted to mention that, or maybe clarify, it is not a gravity only issue. I think, we recognize that across our ecosystem of standard development organizations and implementers is experienced. So we will continue, to help where collaboration can be done to support address it. But just wanted to clarify, it's not only a gravity issue. We have, I think, many other groups experiencing the same.
So ongoing issue, we'd like to hear more thoughts. I see some people making comment in the chat, and so we thank you for that. But we are aware of it, and we, Gravity and HL7, are continuing to figure out how we can address it. The next one is, how does the guidance IG provide a clear distinction for the status of referral versus the status of services requested? So the management of the status of the referral is handled through the task resource and the status of the task resource. The service request itself, the status is managed by the referring organization. So when they see the task is complete, they can determine whether that's the case and then update their service request appropriately. As far as the procedures performed, there is a procedure profile which could present status, but that's sort of background here. Let's open it up, see if there's more questions or thoughts on that.
You answered it as well as anyone could, Corey. Thank you.
Thank you. And then the last one here is about guidance regarding the structure map resource and questionnaire. So for background, because I'm expecting that most people aren't familiar with this, the assessments, questions, surveys that a patient fills out is handled through a questionnaire resource, and their response is called a questionnaire response. That includes all of the the answers to that questionnaire. Then there's processes to convert those into observations or even conditions. That process to convert them involves algorithms that converts the answers into these observations, into these discrete observations and conditions. That may include scoring and things of that nature. This is done through a structure map resource in FHIR. And a structure map resource has these rules and logic to convert that data. So in order to make sort of these questionnaires, these assessments useful or available through this IG, there will have to be an authoring of these questionnaires and in the structure maps that manages the extraction of that information. So we have a couple of examples of these in the IG today. That would be Prepare and the Hunger Vital Signs. And so to the uninitiated, this may look somewhat magical, and we want to get rid of that magic, right? We want to make it approachable and understandable for organizations, both to craft these things and to understand what's happening in a structure map, right? So if an organization provides a questionnaire with a structure map, the rules or what's going on, the actual business logic that's happening should be expressed as well. And so this is a thought that's been crossing my mind since I've joined this effort, and I'm thinking about it. I don't have a solution yet for it, but I'd like to hear others' thoughts on it, particularly the person that asked the question, if you're on, if there's anything that you would like to see to improve this.
Hi, Corey, this is Lisa. This is my question. So what I would like to see is, I know how hard the organizations who produce these standardized assessments, how hard they work to create them, to vet them, to perfect them, to test them, to get them really validated. And they are a wonderful resource to the community to have vetted, tested assessments like this. And so to me, they're a pair. I mean, in a digital world, they're a pair. If an
Agreed.
organization is going to produce a questionnaire assessment and go through all that trouble and invent how it works, if you answer, yes to this and no to that, then it means this, or if you ask yes to this and yes to that, then it means something else. Or sometimes they have more sophisticated things where if you answer one of these things, you get a 2, something else, you get a 5. At the end, you add them all up. If the score is higher than this, it means one thing. If it's lower than that, it means something else. It's part of the design of the questionnaire. And I believe that the organizations that produce the questionnaires these are the questionnaire resource. The questionnaire is a resource that represents the assessment. The questionnaire response is one of those things filled out when the answer's in it. But the organizations that are really designing the questionnaires, they should make a pair. They should make the structure map that goes along with the questionnaire so that implementers get both of those things as the resource that you can use. It tells you what questions to ask, what answers to allow, and how to evaluate the thing so you know what observations to produce as a result of getting a certain questionnaire response back. I really see them as a pair.
Yes, I agree. I think there's agreement with that. We could look at making that clear in the IG, and I hope I'm not speaking out of turn, but I would like us to see. Yes, sorry.
Oh, sorry, didn't mean to.
Like to see. Hopefully, you can reach out more to these organizations that have worked on these questionnaires, vetted and tested them, to see if we can adopt more directly. But that's my own personal. Sorry, go on.
Yeah, one area that could use a little bit more clarity is just how the rule sets work, right? It's easy enough to look through the JSON and excuse me, to look through a FHIR resource and see the data element for rules, but in terms of converting a series of rules or like really kind of walking through it as an exercise, I think that could be clarified or made more easy to understand for.
All right. Yeah, and there are tools out there. So the structure map uses the FHIR mapping language, and there are sort of tutorials there for that, and we could make that more directly available,
right,
and get that out there, and then we can see what additional things we might be able to do specifically in Gravity.
I think making them more prominent within the documentation itself. I'm aware of that, but just.
Okay. I'll add that to the list, our list for our SU update. All right. I think we're at time now. Gabby?
Yes, thank you so much, Corey, for navigating us through our first set of questions. Again, this is a two-way street and interaction between our audience, implementers, and the Gravity team and collaborators, because I think we're all in this together as a really unit on trying to move forward the exchange of data elements as it relates to social determinants of health. So we really want to welcome all the questions. I think there was a email share in the chat. You can email us. That will be the best way for us to route them and make sure the internal team gets a chance to review and you get a full response. Just from an admin update, we are composing a frequently asked questions document that will be posted on Confluence. So this first set of questions will be the first ones featured there. It will be an active document. So as questions come in and answered, they will be logged into that FAQ document. So with that, and being mindful of our presenters' time, we're going to segue into the next section. Really want to thank Corey for his time and effort during today's call. Thanks, Corey.
Hey, everyone.
Great. So we're going to pause here, a transition for our upcoming speaker. It is an honor to present a really amazing team. And before we go into that, actually, Lucy, this reminds me of the question that you asked about the requirements to be part of the pilot Affinity community. This is a learning forum. So there's really two levels of participation as it relates to this forum. You can come in as an observer, where you're not committing to test any of the gravity standards, but you really want to follow along, be part of the discussions, bring in questions during these calls and via email. And then the other type of participant level is pilot participant, where you want to be part of the what happens behind the scenes as it relates to validating the standards and providing feedback. The approach that we have developed is incremental, where the tier 1 reflects the minimum requirement to be a pilot participant, and is by using the infrastructure developed by the terminology team as it relates to the codes, screening, diagnosing, interventions, goal setting. So those 4 activities that we have worked on, the terminology associated with that by domain. Then segue into tier 2, which is that for a pilot participant to be able to exchange that data through established content and transport standards. Some examples you'll see here. And today's presenter is actually a tier 2 pilot. So you will get to see a real life example of what that looks like. We're extremely excited. And then just briefly mention the tier 3. It is the Gravity Fire IG, the presentation that Corey just went over, and being able to continue to make it more approachable. So without further ado, our today's presenter will go over this presentation outline, and I will pass the mic over to David and Ida from the DC Community Resource Information Exchange team. So I will stop sharing now, David, and please feel free to pull up your presentation.
Great, thank you very much. Good afternoon, everyone. I am actually gonna pass it to Ida first, and we'll tag team a bit on this. So take it away, Ida.
Sure, thank you, David. So hi, everybody. My name is Ida Samara, and I'm a project manager for social determinants of health at CRISP DC, the designated health information exchange in the District of Columbia. And today we're going to be talking about a project that we have with the DC Department of Healthcare Finance and a couple of our other partners called the DC Community Resource Information Exchange Project, also known as CORI. But before we go into the next slide, I'll also just hand it over to David to briefly introduce himself.
Oh, I forgot to do that. Yes, I'm David Palms. I am the partnerships manager at the DC Primary Care Association, membership association for the community health centers, federally qualified health centers in the District of Columbia.
All right, so moving into our pilot team. So we've introduced myself as CRISP DC, the HIE and technology vendor as a part of the CORI project. We also have David Palms and Donna Ramos Johnson representing the DC Primary Care Association, Greg Bloom and Devin as a part of the Open Referral Initiative and supporting us with resource inventory management. And on the call today as well, we also have Denise Sawyer and Asfia Miriam representing the DC Department of Healthcare Finance, also known as DC Medicaid, and supporting us with the CORI project as the funder and DC HIE regulator as well. Next slide. All right, so we'll start with introducing our partners. We have one slide each. So we'll start with the DC Department of Healthcare Finance. They are the administrators of the DC Medicaid program and oversee the DC Health Information Exchange Marketplace. So they are the state health IT coordinator, also the regulator of the HIE, and manage the registration and designation process for HIEs operating in the district. They're also a strategic leader and convener. So they convene stakeholders from the DC HIE Policy Board and make sure that the district is remaining responsive to the evolving digital health needs in the district. And they're also, most importantly, the funder of the CORI project and partner as well. And we also have CRISP DC. So as I mentioned, we are the designated health information exchange in DC. We're also a regional HIE serving Maryland, West Virginia, and District of Columbia. We're a nonprofit organization advised by a wide range of stakeholders, making sure that we're responsible for public health throughout the district. And our main goal as CRISP, also known as CRISP Shared Services, is to securely deliver the right health information to the right place at the right time to enable safe, timely, effective, equitable, and patient-centered care. We've been serving DC since 2016, and we became the district designated HIE in 2020. And just for our users at a glance, we have over 14,000 users connected to the HIE, over 1 million patients served through the HIE, and over 900 organizations participating, accessing data, and contributing data to the HIE as well. All right, and as a part of the DC HIE, we have 6 reliable core capabilities. So for those of you who are familiar with the Health Information Exchange, historically, the HIE has been a hub of clinical data, traditional clinical data that is. So ADT alerts such as admission, discharge, and transfer messages, health records, allergies, medications, etc. So that's what we mean by our critical infrastructure as our first component. We also have a consent to share data component, a registry and inventory, simple and secure messaging, and advanced analytics for population health management. And as a part of the CORI project, we also introduced a screening and referral component for social needs screening and referral data sharing, as well as a community resource inventory. And all three of these components will be the focus of the presentation today. Next slide.
So I'll jump in and talk about the DC PACT Coalition, Positive Accountable Community Transformation, which started as an accountable health community applicant for the CMS AHC application and has since added on the collective impact model, those two models that you see at the bottom of the screen here. And so the coalition is made up of social service, healthcare, and public and social care organizations in the district, serving the District of Columbia. DCPCA is the backbone. This is the framework that we use for understanding social determinants of health. You can see from left to right the social and institutional equity driving disparate living conditions, which result in disparate health-related social needs and prevention, wellness, and care outcomes. And so we view the CORI initiative as part of our work to go upstream, establishing first sort of the downstream activities around managing social risk. And I'll talk a little bit about how we talk about our strategic goals in this way, but just to give you the big picture of the coalition, that's really the community organization center of gravity for a lot of the work that we've been doing over the last several years.
All right, thank you, David, for introducing DCPCA. So now that we've introduced our partners for the CORI project, we'll go into more detail about the overall CORI project and what the components are, what are the goals that we're trying to achieve, and what are the tools that we have available, just to level set before we go into the specific pilot project that we have as a part of this larger initiative. So first and foremost, as we mentioned, CORI is a partnership. So we have the DC Department of Healthcare Finance, the DC HIE, also known as CRISP-DC, the DC Primary Care Association, and the DC Hospital Association. And our main goal is committed to supporting and sustaining technical solutions and enabling coordinated whole person care across health, human, and social service providers in the district. And we're seeking to accomplish three technical functionalities to address SDOH. So the first one is screening for social risks and sharing those dispositions, being able to look up resources through a centralized community inventory, and then being able to refer to the appropriate community and support services, all through a vendor agnostic approach. So one partner I forgot to mention was Find Help, and also known as Ambertha. And they are our last CORI partner that I wanted to highlight in this specific slide, because what we mean by a vendor agnostic approach is we want to make sure that the HIE is a hub of social needs data across various sources. So whether that's a specific EHR or a social care vendor that an organization is using, in this case, Find Help, and making sure that regardless of the vendor or platform being used, we can have social needs information captured within the HIE. And that's why we're partnering with Find Help to make sure that we're addressing this goal and really remaining vendor agnostic, similar to the Gravity project, as well as building a truly interoperable system within the DC HIE. Next slide. So this slide goes over the tools that were developed as a part of the CORI project, as well as the data sharing opportunities. So we'll go into the first pathway, which is for organizations that are using a third-party SDOH network platform. I mentioned Find Help as one of our partners that's really supporting our ability to remain vendor agnostic. And we're taking in referral and screening data from third-party platforms such as Find Help and making sure that for clients of theirs that opt to share data with the HIE, we're making that available at point of care within the HIE portal. And you'll see here on the right-hand side, we have a social needs data tab, where you can see that screening assessment data, as well as decode data and referral data captured and made viewable for organizations that submit that data. The second data sharing pathway is for organizations using an EHR. So whether that's eClinicalWorks, Epic, Cerner, et cetera, organizations can opt for sharing CSV files that contain screening data, as well as CCDs or ADTs via an HL7 feed to make sure that we're capturing their Z codes or social needs screening assessments, and again, making it viewable at point of care within the HIE. And I wanted to highlight that for Z codes, as a part of the CORI project, we had 5 federally qualified health centers as a part of a pilot that implemented a structured workflow for capturing social needs Z codes as a part of their workflows and submitting that to the HIE via CCDs. So moving into the third and fourth pathway for participating in the project, these are tools that are developed for the HIE. So first we have a CRISP-DC direct entry screening tool for organizations that don't have a current electronic mechanism for capturing their social needs screening assessments. We've built in a tool where organizations can enter it directly in the HIE and then make that automatically submitted and made viewable for other members of a patient's care team within the HIE portal. Similarly, we have the last tool, which is the CRISP-DC referral tool, closed loop referral tool that is. And that is a tool for organizations that don't have an electronic mechanism for capturing and sending referrals to community-based organizations. So they can use the referral tool to communicate and send referrals to community-based organizations in the district. The CBOs on the receiving end can respond to the referral and close the loop, changing the status from pending to accepted, rejected, disenrolled, or completed, and also communicating any free text information that's relevant to the outcome of the referral, making sure that both the receiving provider and the CBO can make sure that they are on the same page, as well as other members of a patient's care team as well, because that information is automatically made viewable within the care coordination tab for other members of a patient's care team to view. Next slide. So our last component of the CORI project is the community resource inventory. And the CRI is a district-wide publicly available directory that provides information about health, human, and social service organizations in the community. The data available in the CRI includes information such as organization, program description, location, address, phone number, contact information such as email, etc., and also service category, service eligibility, and more, which we'll be talking about later on in the presentation. And it's built in collaboration with various data stewards that are curating information about community-based and social service organizations that address unmet social needs. And it's a component of the DC HIE and is currently maintained by the DC Primary Care Association in partnership with the Open Referral Initiative and technology developed by Serapis. And the main idea for the CRI is to look up and identify resources and make sure that organizations and healthcare providers can refer to the appropriate services in the district. Next slide. And this is a diagram that just goes over the main ways that organizations can share data and the value add for sharing data with the DC CRI. So we're taking a data stewardship approach where organizations that are maintaining resource directory, resource information for their own services or within their own social domain can contribute that data and share that with the DC CRI. And then on the receiving end, they can also receive updated resource information about their own services, about other services, outside their own domain as well. So for example, it can be agencies or any other coalitions or collaboratives or resource directories that are maintaining information. They can share that and get that information, additional information back for resource directories that they may be hosting. And in terms of the 3 ways to access the DC CRI, you can access it using the public accessible website, so dc.openreferral.org. You can also access the CRI via the DC HIE. So we have a tab where HIE connected providers can view that information. And you can also pull in that information to your own directories via API as well. And here we have some screenshots on the CRI, sorry, David, about how it looks within the DC HIE portal. So you can search by the organization name itself, by category. So you can see we have care, emergency, goods, legal, work, education, food, housing, and money as categories you can search for. Or at the top of the CRI, you can also view a full list of the services and organizations that are made viewable in the CRI. And you can see here, for example, in the screenshot on the right side, you can see a service category and service eligibility as further criteria you can use to search for the appropriate resources for your patient.
Great.
And I'll
So
turn it over to you, David.
Thanks, Ida. So I'm going to jump into the specifics of our pilot. So the business drivers here you can see coming from DHCF and DC PACT and CRISP. As partners, you can see the reference to the DHCF State Medicaid Health IT Plan, which prioritizes collection, exchange, and use of SDOH data. DCPCA, the DC PACT coalition has strategic goals around incorporating social risk management into value-based payment and quality improvement forums, as well as ensuring that our partner organizations are using HIE-connected solutions for social risk assessment and analytics, resource location, and care team coordination. So you can see the vendor agnostic approach reflected in that language. And then as well, CRISP, as Ida described, is the designated HIE and is committed to serving our market with the resources needed to connect care partners for actionable social needs interventions. So our pilot is hypothesizing that we can enhance the overall navigation and referral process by creating sustainable and trustworthy referral protocols within the CRI tool using Gravity Project codes as service level metadata. So there's sort of two steps to that. The first is deploying Z-code search within the searchable CRI page that was just shown. And then secondly, deploying Z-code search and intervention tracking in the CRISP closed loop referral tool and ultimately in the patient record. And so incorporating that metadata into the referral tool in the patient record. Basically, our idea here is, users of community resource inventories need sustainable and trustworthy CRI data that's accurately maintained and up to date. Standardizing the display of information as it regards from screening to diagnosis to referral to interventions, aka protocols, can help navigators at the point of care in decision making, and as well then closing the loop, as many folks who are using closed loop referral tools know, enables intervention tracking and quality measurement over time. Did someone receive that service? Did it make an improvement? And so we're sort of focusing here on, how do we improve the whole navigation and referral process by using Gravity Project codes as that metadata. So within the CRI, CBOs are listed, and again, the link for that public facing website is dc.openreferral.org. Community-based organizations or an intermediary like a data steward can utilize the tool. They can log into the tool, verify the information about their organization. They can classify their services using various taxonomy schema, including Gravity Project, conditions, goals, and procedures, the human services data specification, the 211 LA/Maryland specification, and the open eligibility specification, which was created by Find Help. And so you can see an example screenshot here from the back end of our CRI, listing codes across conditions, procedures, and goals. You can see the language, and on the right, the organization. Almost to the end, there's the actual service that is associated with. I'm going to go into more detail about the Produce Plus program at DC Greens, which is the bulk of these entries here. So this is the page for DC Greens, and we're logged in. You can see the status. And you also see here this Produce Plus program at the bottom, which is a program where folks who are receiving federal benefits like SNAP or WIC or TANF can receive an extra $10 to spend on produce up to twice a week at DC participating farmers markets. If you look more closely at the page entry for Produce Plus, you can see this little pencil on the top hand side. And so a staff person at DC Greens can log in and edit their page, edit this information as it changes or as the case may need to be changed. And so you can see here, they have access to what I would refer to as the human readable fields, free text fields, or some drop-down menus that go to some of the basics of the organization. You can see a change log associated with the page. And then what you can see when you go in and you're editing a page is a list of social needs codes coming from the Gravity Project. So you can see that the food and security box has been checked off. And then the conditions, all of the different conditions that have come from the food and security domain are listed here. And we've set it up with the simple 1 through 3 drop-down menu. You can see in small letters here sort of the description of what is to be done with this page. Essentially, 1 is that this program is not appropriate for this condition. 2 is that it might be contextually appropriate. And 3 is that it's almost always appropriate as a first referral for someone who might be experiencing a particular Z code. And so in this case, you can see that the Z code or the condition language that was put in here is insufficient food supply is a condition that is very relevant for the Produce Plus program. And then likewise, they can scroll further down, they can fill out relevant goals that a patient might have that also are contextually or always appropriate. And then they can fill out the actual activities, the bundle of activities that make up the service. And so you can see here under provision, the provision of fresh fruit and vegetable voucher is the procedure that's associated with this project. And you can fill this out with as much of the activities that are relevant, really breaking it down to the component level. So using that data, we will be exchanging the data that makes up the gravity terminology value sets using the established content and transport standards that are already in use. So the closed loop referral use case, as well as quality reporting use case. We'll be adding service level gravity metadata to over 50 services in the CRI, built around some of the main referral partners that federally qualified health centers in the city are working with. In the second quarter of this year, we'll be testing with the health centers the ability to search by Z code, really managing the data that's listed in there with the understanding of the staff who are most often working with those organizations, making sure that that metadata is appropriate and easy to understand in ways that we would be potentially redeploying it, starting by enabling a search. So simply using a drop-down menu of Z codes that have programs relevant to them that organizations have self-identified as being relevant to this particular Z code. They'll be able to see that information in the searchable resource inventory database. And then by the end of the year in Q4, we anticipate being able to use the API feed from the CRI to make this information be part of the referral tool within CRISP. So I'm going to go a little bit deeper into each of these, but you can see the participating partners here. So these are the system roles. Tier 1 and most of Tier 2, we don't have a patient application component at the moment, but we are utilizing the rest of the roles that are listed here. So we're capturing data, storing it, using it, supporting intervention workflows, whole 9 yards on the left-hand side, the care coordination platform, and referral source and referral recipient all happening within CRISP, as well as potentially within other systems like Find Help that are connected to CRISP through data sharing. So the terminologies, standards and technologies that are in use here. So we're focusing on food, housing, transportation, and financial instability services. Again, using the diagnosis, goals, and intervention terminology, data elements, and APIs from the CRI as well as the CCDA exchange standard. And that's from the EHRs to CRISP. So here's just a different way of explaining that. So our health centers in DC use ECW. CRISP has the CRISP DC portal, the core features of which were described previously by Ida, and then the community resource inventory that DCPCA manages, and the API feed ultimately supporting that CRISP referral tool. So just to dive deeper into the workflow, again, we'll be adding metadata to 50 services across food, housing, transport, and finance. What you're seeing on the right-hand side here, this table is from the initial structured pilot of the Z code workflows being added to SDOH screening that's happening in 5 of our health centers. So you can see the distribution of Z codes, and that'll be reflected in how we prioritize which services would have some of this metadata attached to it, so we could begin to analyze it more closely. So we'll be collecting that data, enabling the ability to search for Z codes in the second phase. And then CRISP DC will build out an internal program directory for the CRISP referral tool, which will support searching for programs based on all of the different data points that are associated with services like location, service category, eligibility, and the associated Z codes. So they'll be able to see that information in the closed loop referral tool, using that to direct where they might make a referral. That Z code information, as well as the intervention information, would be considered part of the patient's referral record and ultimately their own record as it relates to the services that are provided and marked by status according to the referral record. So this is the timeline for the pilot. We're just kicking off. We'll be doing the engagement with health centers to understand, which services ought to be more thoroughly combed over for, provision of the metadata on the records within the CRI, testing some of that with the CBOs themselves, and then testing the search with health centers by May. That would complete phase 1 and 2, and then digging into how we use the API to enable that search functionality within the CRISP referral tool by December. And so there's some challenges, particularly, bandwidth from health centers to, look at how their workflows might change with this. Some of them are already, capturing Z codes for different populations. Where does this sort of tool fit within the existing workflows? How do we improve overall, FQHC ability to handle and manage, social risk and unmet health-related social needs in their patient populations is a broader challenge that DCPCA and DCPACT are looking at. And so this is a tool for that we hope to, grow that type of work that's happening. And then similarly, the Corey team, does a lot of work to engage community-based organizations in the district, connecting them to using HIE. We've put a lot of time and effort into enabling ways for example, non-HIPAA covered entities to participate in the HIE. That includes not only the technology, but also the governance related aspects of this. So getting community-based organizations who are using that referral tool in a way that has the metadata attached to it. We're looking to continuously engage with community-based organizations to make sure that they're aware of these tools that are available to them. So our success metrics, an increase in FQHCs and other provider types using the CRI to search for Z codes, as well as using those Z codes to search for programs and make closed loop referrals. And finally, being able to see at the point of care the Z code that has led or could lead to different social needs interventions that might be referred to. And then I'll just close out. We have several resources that you can explore further. The link to the actual CRI, the state Medicaid health IT plan from DHCF, some information about DCPACT, some background on our resource inventory strategy at the open referral website, as well as shout out to Data Across Sectors for Health. I think I saw some DASH folks on here who supported our governance on the CRI. Details of that are in the issue brief that was published last year by CHCS. And then you can find out more information about CRISP DC and their Corey web pages here listed on the slide. So that is the end of the presentation. I think we'd be happy to take questions. I see the chat, so I'll take a look at that.
Perfect. Thank you so much, Dave and Ida. That was a lot of information to digest. So we do have a few minutes for some questions. I want to make sure I open up the room, and I will mention that some of your colleagues have been answering questions throughout the presentation. So that's great. We'll take a look at that. I do see a hand raised. Lucy, feel free to speak up. Thank you. If you're talking, we cannot hear you unless you're on mute, Lucy.
I'm sorry. I started by saying I hope other people are going to pop in here. I have two questions. First was a little bit answered in the chat, but basically I'm interested in the long-term business model for this quite complex and extraordinary endeavor. I understood that Medicaid is paying for it right now. I asked whether this is a routine thing that any Medicaid program could fund, or does a waiver have to be done? And if it's a waiver, what's the long-term business plan? That's the first question. And the second, much more specific, what kind of training are you doing at the FQHC level to be sure that the people who actually have to implement this understand what to do? Thank you. Financing and training.
Thank you for that recap as well. I think the question was in part answered by my colleague Denise Sawyer in the chat about the funding. Comes through DC Department of Healthcare Finance. It was originally developed using high tech, and we're continuing through to Medicaid Enterprise System funding. High tech and Medicaid Enterprise System being hopefully meaningful to you or others who are familiar with Medicaid funding streams, but essentially, establishing these functions in the HIE allows us to draw on federal Medicaid matching funds. And so that's the big advantage for DHCF being involved in funding this, is the ability to draw down federal resources.
Okay, so I don't, excuse me, I don't understand Medicaid enterprise funding. Is that a routine that any Medicaid agency can engage in, or does that require a waiver?
Denise, maybe you could jump in and answer that question.
Yeah, sure. Happy to. So first of all, Ida and David, great presentation, you guys. It was great to just be in the audience and sit back and listen to you guys present all this extraordinary work that you have implemented in partnership with us and other associations in the district. Lucy, this is a great question. We initially leveraged high-tech funds to design and develop and implement the three major core capabilities of the CORI initiative that Ida walked through. As you know, as many of you know, high-tech sunsetted in 2021. And as an agency, and other states have done this too, HIE artifacts are now funded through Medicaid Enterprise Systems funding. It is a different bucket of funding, and it continues to support design, development, and implementation efforts. And this is a 90-10 match, federal to local match. And then they also offer another bucket of funds for operations and maintenance to sustain HIE infrastructure that was fully developed and implemented through high tech. So one sub bucket of MES funding is for design, development, and implementation. That is what is currently funding the CORI initiative. And there's also an operations and maintenance bucket, which we use to fund and sustain our more mature, I'll say, HIE artifacts.
Thank you. Thank you for that.
Yes, of course. And then to directly answer your question, we do not use a waiver or other Medicaid funding methods for this.
And to your other question, DCPCA provides quality improvement training to health centers. So for this pilot initiative that we're embarking on now, we already had done a first phase around capturing Z codes in the screening workflow. So we provided tools. We also provide technical assistance with ECW. So we were able to be fairly hands-on in designing a workflow that fit the needs of the health centers to use ECW where it made the most sense for them to use ECW.
Thank you all.
Perfect. I'm gonna scroll back a little bit. David and Ida asked some questions from the chat that I don't believe have been answered. I think some of them may be a little bit of overlap answers there, but Tom is asking, when a social determinants of health search is initiated outside of a healthcare provider, how does or does not, how does that occur? And then the CORI lookup and identify unique individuals to ensure that their information is associated with their appropriate EHR record. If you don't mind, I think sharing a little bit about that integration with the EHR.
Go ahead, Ida.
Yeah, so if I understand the question correctly, the question is asking how we're able to identify patients whose social needs data is sent to us from external systems, whether that be EHRs or Find Help or any other third-party vendors being used to collect this data. And so CRISP is taking in this data, whether it be through CCDAs or ADTs or through CSV files. And we have a master patient index, also called an MPI, internally at CRISP, that is able to make sure that we know which patient is which based on demographic data that is submitted to CRISP. So a little bit of more context for HIE connected organizations. Every organization is submitting a patient panel in order to access data for their patients in the HIE. And we have all of that data updated on a quarterly basis. I believe every organization has to submit a patient panel on that regular cadence. And we know that we have the most up-to-date demographic data, whether that be first name, last name, MRN, date of birth, address, zip code, et cetera, phone number. And we use that data to make sure that any data that's coming through to the HIE, we can match it to that MPI and all that data stored in one place and make sure that we know which patient is associated with each organization, EHR, data source, et cetera.
Wonderful. I hope that supported. Again, I'm just going to go down the list of some of the questions that I see outstanding. And Tom, please feel free to speak up or share in the chat if that supports the answer that you're looking for. Then Lashana is asking, I think like a 3-part question. As you were going into your presentation, is this portal only for DC area? Second question, does the portal assume C codes are submitted? 3, are you working with the vendors mentioned, such as Find Help, to standardize the taxonomy?
So I can take that one as well. In terms of the first question, is this portal only for the DC area? If you're speaking about the DC HIE portal, the HIE portal itself is available for any HIEs that are utilizing the CRISP technology for their respective health information exchanges in their state. So it's not only available for DC connected healthcare providers, it's also available for any states that are using the HIE portal for their HIEs as well. But if you're speaking about the DC CRI, then that is available for only DC HIE connected providers, a part of CRISP, but it's also available outside via a publicly accessible website at dc.openreferral.org. For your second question, does the portal assume Z codes are submitted? So the way that the portal recognizes that Z codes are submitted to CRISP is through 2 ways that we allow them to be submitted. So via ADTs or CCDs or CCDAs. And so we know that if Z codes are coming through those 2 sources, we're able to recognize them. In terms of CCDs, we're able to parse them out, as we're doing with the federally qualified health centers that are sharing them through CCDs, and make sure that we're extracting them from those documents and displaying them at point of care. So if they're coming through those 2 sources, which is the primary ways that we're allowing the Z codes to be submitted, that's how we're able to recognize and make sure that we're displaying them. And then the third question, are you working with the vendors, Find Help? We are working with Find Help to share screening and referral data captured in their systems. So we've worked with them to make sure that we're mapping their, for example, I can use the example of referral statuses. We're making sure that we are using the same set of referral statuses to display that at point of care in the CRISP portal, and make sure that we're aligned in that respect, to make sure that we're cohesive and making sure that the data that we're displaying is accurate and pretty much lined up to be mapped to be the same. And I think those were all the questions, Gabriella, for that question.
No, perfect. Thank you so much. And there's another one down here from Brian, and please, feel free to tell me if it was already mentioned. What is the incentive for CBOs to close the loop? How does Corey integrate with the tools that the CBOs already use?
That's a good question. The first question for the incentive for CBOs to close the loop, the main incentive that we see, and I guess I can give more context about the HIE in general, is historically CBOs were not necessarily a part of the HIE network or a part of the organizations that have been connected and sharing data with the HIE. So through being able to first be a participant of the HIE, that's the first incentive in the sense of being able to contribute to this large data hub of information that organizations are contributing to and making people aware of, to make sure everybody on a patient's care team is on the same page and is viewing the same information from various sources. So we see the first value add of CBOs being able to contribute to this larger network. The second incentive being CBOs getting more exposure to the HIE connected providers. So for example, if a CBO is not receiving referrals or has no healthcare partnerships with maybe hospitals or payers or federally qualified health centers, then in this case, by being on the closed loop referral tool, for example, you have the ability to receive referrals from these healthcare partners that you may or may not have had exposure to before, and develop those referral partnerships.
I'll just add that part of the reason why I framed our involvement as part of the DC PAC coalition is a desire to see that strategic goal around social risk management being really part of the Medicaid model, and how are we resourcing community-based organizations so that the power is shared more equitably between healthcare and social service organizations is a big part of our perspective. So developing the technology here is in part a way to facilitate future reform in the system.
And I think the last part of the question was, how does Corey integrate with tools that these CBOs are already using? So we did mention, for example, we are integrated with Find Help. There are a couple of other systems such as Apricot and other platforms that we have been speaking to CBOs, and it seems that they're using those as well. And so a part of long-term goals for the Corey project is making sure that we're trying to reduce the number of platforms that CBOs have to log into to receive referrals. So in this case, we have the option of using the CRISP referral tool as well. But in the case where CBOs want to accept referrals from the systems that they're already using, we want to work towards pushing those referrals out to those external systems that these CBOs are using as a part of their workflow, so that they don't have to do duplicative work and trying to accept referrals in all these different systems. So really trying to decrease the burden for CBOs and make sure we're integrating with their workflows as a part of our long-term goals.
Thank you. We have time for one more question. I do see Lucy's hand up and a question in the chat. So I'll let you, Lucy, if you don't mind speaking up, and this will be our last question. Thank you all.
Yeah, addressing HIPAA and all of its implications has come up a lot in the last few years with respect to involving CBOs with healthcare providers. How are you dealing with that?
Yep, so we have a couple of different agreements for CBOs and just organizations that are participating in the HIE in general. For CBOs, and a large amount of them are non-HIPAA covered entities, we make them sign a specific non-HIPAA covered entity agreement where they sign off on only being permitted to use the HIE for the purpose of accepting referrals. Recently, we've also enabled their ability to also use the HIE to send referrals, as well as use the direct entry screening tool to input SDOH screening assessments in the HIE as well. So this CBO MOU essentially permits them to only use the HIE for these permitted use cases. And once that is signed, they only have access to those specific tools within the HIE and nothing else. So they're not accessing any PHI or other information, clinical data for these patients. They're strictly either receiving the referral, sending a referral for that specific patient, or inputting a social needs assessment for a patient that they already have a treatment relationship with. But that's essentially what the specific CBO non-HIPAA covered entity agreement permits.
That's really helpful, and I'm wondering how the FQHCs are responding to that. Is that enough for them to feel, or other providers that are going to enter into your system, is that enough for them to feel, to trust relating to the CBOs that you're bringing into your system?
So we have a CRISP DC clinical committee that I can use as an example, where we get input from our hospitals, our FQHCs, our payers, to make sure that they're okay with the different types of organizations that we're introducing into our network and the different use cases that we're trying to permit in the HIE. So this is something that's been discussed at a higher level with all of these leadership at these MCOs and payers and FQHCs, and at our CRISP board committee meetings, to make sure that everybody's on the same page and wanting to enable this use case and allow CBOs to be introduced to this network. And it's been met with positive results. I think any healthcare provider would love to have more social care providers included into this network and contribute data, and make sure that any member of a patient's care team can see data contributed by traditional clinical providers, as well as the CBOs that are a part of their patient's care team.
Great, thanks very much.
Awesome. I really want to just take a moment to thank the entire team. DC, Corey, thank you all so much. This is really a lot of information, very exciting work that you're embarking on. And just as a reminder, in terms of result and information about how things will go, our pilot participants do commit to do a total of 2 presentations, one an introduction, just like DC Corey team did, of letting us know their goals, their scope, their partners, and then a result presentation towards the end of their implementation, their pilot implementation efforts. So we will definitely hear back. I will transition us into our next section of the meeting. I'll continue to welcome comments and questions in the chat, and we'll answer them the best way that we can. But before wrapping up, I would love to send a virtual applause to DC Corey. Thank you so much for taking the time today.
Thanks for the invitation. Appreciate it.
Thank you, everybody.
Great. Thank you. So we will transition into our next section. It has been a full meeting, a full agenda. So thank you all so much for staying with us. The next session is really to connect you with each other. Part of this learning forum is to listen to the Gravity team, provide updates and share announcements, as well as be able to, if potentially have some matchmaking partnership opportunities. So some of you have signed up as pilot participants, really looking to stand up a pilot within a specific focus on the tier levels that we have discussed so far. So I'm going to share and give a shout out to those entities that are looking for partners. So this will be a good opportunity. I will note today's session is being recorded, as well as it will be posted on Confluence site for anyone that maybe came in a little bit later. You'll get to see the full content on our page. The best way to contact the entities that will be presenting will be to send them an email directly. You'll see their contact information. So it is, I think that will be the most direct way. So we'll go ahead and start with and Green Health. I know the lead is Karen Thomas. I'm not sure if has joined us today, but she is looking for federally qualified health centers or Medicaid providers and social resource organizations in Tennessee and the Southern Appalachian region. Their scope is tier 2. So being able to use content and exchange standards that are non-fire, maybe the roadmap to fire in the future, but just wanted to give them a shout out here. You'll learn about their health equity program if you're interested in joining them, and they really hoping to finalize partners by May 2023 or sooner if possible. Moving into the next one, and if for any of our leads that are on the call, if you'd like to say hello as I go over your entity, please feel free. We also have BitFocus. I did a presentation in November. They are looking specifically to do a tier level 1 pilot. Their domain of focus is housing instability. The direct lead is Eric. As you can see, this is the contact information. Again, really the best way to make some discovery and next steps will be to contact our leads here directly. Moving right next to the next one, Electronic Services Technology is looking for community-based organizations. They want to support a gravity pilot, and their focus is food insecurity as well as supporting the National Diabetes Prevention Program via their EHR and data collection reporting tool. Scope is tier 2 and timeline is flexible. The lead is Joe, and he will be very happy to take discovery calls with any organization that are interested. You'll see a mix of partners that are really eager to get our pilot going. The next one is Humanad. P did presentation in November, and he specifically is looking for clinical partners using Epic systems. They would like to do a tier 2 interoperability project connection through the electronic health record, their EHR system. So really regional or nationwide. And as you can see, this is his contact information. Then shout out to our audience who, Lisa Nelson, who provided questions for today's office hours. She's looking for partners with a client system that would like to initiate the patient screening task and is really being able to test the full IG. The timeline is to be determined, is flexible depending on the partners that come to the table. Here is Lisa's information. You may remember MuleSoft, Salesforce from our November meeting. They're looking to partner with health systems, community organizations that are collecting social risks data in a standardized manner using the Gravity standards. Their scope is tier 3, so being able to support integration through FHIR resources and expand the management of social determinants of health. They have been conducting discovery conversations, and they're really hoping to complete their recruitment in this month or in the next month or so. Peter Herman is the point of contact, and again, the best way to reach out is to email him directly. Open City Labs, we had our Gravity friends for a long time, Matt and Brian, who are always eager to partner and being able to continue to test standard-based exchanges. So they are also, their focus is tier 3, and they did a great presentation in November as well. Just trying to be mindful here of time. Patient-centric solutions, Nancy Lush, who I did see on, I think on the call, she will be very interested in supporting a pilot, putting all the pieces together to do an adoption and implementation pilot under tier 3. Timeline is flexible, as you can see here, the contact information as well. So I did want to mention, if anyone that I just gave a shout out to is on the line, you are welcome to say hello or express any other criteria information that you would like to share with the audience. I'll give people a couple of seconds.
Hi, I'm Joe Williams from Electronic Services, and I thank you so much for making this forum available. And again, I am looking for entities that want to pursue the social determinants of health, in particular in the underserved marketplace. So I'd love to talk with any individuals that are looking to provide those kinds of services, particularly CBOs. Thank you.
Wonderful. Thank you for the support. Great. Awesome. And we are coming down here to the wire. We have just about less than 5 minutes. So we really want to thank all of you for staying and being able to continue to support the implementers. I'm going to walk us through some closing remarks and kind of, close our meeting out today. So as a brief announcement, I would like to share that there will be an information session on the Gravity Project on Thursday, February 2nd. The session is hosted by Civitas, and it will be a really good opportunity for those who are new to Gravity or want to get more involved on implementation efforts to attend. So as you can see in the chat, there is a registration link, and it is next week already. So I encourage you to sign up if you're able to attend. And thank you all so much for the continued.
Could you please send an email with that link to register to all of us? Thanks a lot.
Absolutely. Yes, we will. We'll send an email once a recording. It's all together as well as a registration link. Thank you, Lucy. And what's coming up? So as mentioned, this first phase of our pilot implementation learning forum has been composed of 6 meetings. Right now, we just concluded our meeting number 4. We'll be having some result presentations, and if the audience submits questions regarding the IG or terminology that you would like the Gravity team to support with, please email us. We'll be happy to bring them on our next call, which will be on February 23rd. If you're interested in piloting, the best way is to sign up via Confluence or contact Denver and myself. You'll see that email, the sign up form in the chat, and our email addresses as well here. Without further ado, I want to thank you all for continue to participate in this calls. I think we had the most attendance today, starting the year on a good note. And you're all being part of this implementation process, learning with each other and being able to share challenges as well as gains. So we really want to thank you all. And with that, I'll give you back a minute or so. If there are any last minute questions or thoughts, we'll be here until 4. Yeah. Thank you so much.
Great job, Gabby. Thank you.
Thank you. Wonderful. All right, stay safe out there. Thank you all so much, and we'll be in touch. This will conclude our meeting. Thanks. Thank you, Demery.